Hello, good evening, everybody. That's a lovely promo video, isn't it? Good evening and welcome to the brand new show from Tomorrow's Podiatry, Two Views, where we encourage a little antagonistic cooperation in the form of some friendly debates. My name is Osama Khalid and I'll be your host. I'll be channeling my inner Fiona Bruce tonight. I'll be joined by team captains Zoe Wilson and Jeremy Uzi, who'll be joined by their experts in their field. Today we have experts Dr. Ivan Bristow and Mr. Martin Fox, where they'll be hashing it over what is more useful in clinic, a handheld Doppler or a dermatoscope. Today, team captain Zoe will be joined with Dr. Ivan Bristow and team captain Jez will be with Martin Fox. Viewers, you've got an amazing opportunity to learn about the world of vascular podiatry and podiatric dermatology from experts in their field. Feel free to get involved in the debate by commenting below. It's way more fun that way, asking your questions and offering your opinions. The format of tonight's debate is as follows. Each team will have 4 minutes each to offer their argument for what they believe is more useful in a clinical setting, either a Doppler or a dermatoscope. Once each side has argued their point, each will get a chance to reply and rebut the argument the other side has made. Viewers, feel free to get involved throughout the debate by commenting your views in the comments box below. Finally, each side will summarize their closing points, followed by a vote by you at the end to decide who our winners are. Hope you're sitting comfortably. Let's begin. So we'll start off with the opening arguments from the dermatology side. Team Captain Zoe, your 4 minutes begins now.
You're on mute.
Unmute.
You need to unmute, Zoe.
Hello, can you hear me now?
Yeah.
Sorry, I thought
You
it would
can.
unmute itself. Can I start my 4 minutes again?
Yeah, you can start your 4 minutes again, Zoe. I'll be generous on this occasion.
I'm really excited to speak to you all today about dermatology, and I've made a few placards here to speak to you about the prevalence of skin issues that we have in our country. So London, we have a problem. A third of the population have a skin problem at any one time. 59% of adults have a diagnosable skin issue at any one time on the foot. 25% of all new GP consultations are that of a skin issue. Very few GPs have training on dermatology. And so it's a huge opportunity for the profession to progress forwards with this diagnostic tool. Sorry, get these in the way. So currently in the UK, we have 626 dermatologists. So that's one dermatologist for every 100,600 cases, which is a huge number for the amount of skin issues that we're seeing in practice. So moving on to the darker side of things, unfortunately, we need to discuss skin cancer. And the rates are increasing at an alarming rate. 7 people die every day in the UK from melanoma. Melanoma rates, surprisingly, are doubling every decade. Malignant melanoma in the UK, there are 16,000 new cases presenting each year. And for squamous cell carcinoma, 39,000 cases per year in the UK presenting. And the BCC rate, basal cell carcinoma, 146,000 cases presenting, new cases presenting per year. These are astronomical numbers. I had a huge shock when I was looking into this subject further. 87% of melanoma deaths are preventable. We have the opportunity as a professional body to identify these lesions early using the dermatoscope. That is the annual rate of new cases of skin cancer per year, 201,000 cases. I'm sure you'll agree that's a huge number. We're 15 times more likely to spot melanoma utilising the use of a dermatoscope against the naked eye. You could spend one day learning how to use a dermatoscope. I agree, You need many more years of expertise on the different lesions that we come across. But one day to learn how to use a dermatoscope. It's a very simple technique. Is photography permitted, which means that our referral pathways are made a lot easier. We can triage patients and we can record the number and types of lesions that we're seeing very easily to create a bank of different lesions that we can refer back to. It's a unique opportunity for the profession. We have a huge advantageous, 30 seconds. We have a huge advantageous opportunity to utilise the use of the dermatoscope in our clinics. 626 dermatologists is just not enough. And as advanced professionals, we have the opportunity to increase the number of cases that are identified early. Early detection means we are saving lives.
Well, that's a very convincing argument you got there, Zoe. Great input there. Now it's time for vascular podiatry and time to argue the Doppler. So I hand over to team captain Jez. Your 4 minutes begins now.
Thank you very much, Usama. I'm regretting not having flashcards, I have to admit. Although I guess I just have to remember what I was thinking rather than looking at things like through dermatoscopes or whatever. So 1 in 5 people over 60 will have peripheral arterial disease, and 1 in 4 will likely have cardiovascular disease. And when you have access to a Doppler, you're actually able to identify that potentially. You, as podiatrists, I'm sure we remember when we were students and possibly a little bit beyond as well, will have been palpating pulses and occasionally might have fudged it thinking you think that they should have a pulse that's palpable, but even though you think you could, you didn't really feel it properly. So having a Doppler actually gives you a much, much more objective classification of the pulses and the quality and their risk of, well, life-shortening, life-threatening diseases. So to start with, Doppler is going to save life and limb. It also helps to separate vascular cases from the MSK cases. Certainly for me, my main interest is in MSK. I also play with a bit of ultrasound. I do have a dermatoscope, but ultimately, whatever happens, you've got to be able to check that there is blood flow in the area. So although there is some seriously worrying statistics there on the dermatology side, 20% of people who are in our caseload, and actually our caseload is made up of the over 60s for the most part, we're going to need a Doppler. We're really, really going to need a Doppler to identify what's going on. By having access to a Doppler, you're going to be able to heal ulcers and also get everything healed up quicker. And, you know, when you cut out that dodgy looking skin lesion, they'll probably heal up after and not ulcerate as well, which I'm sure would be appreciated by all, having a bit of a shaved biopsy or whatever. When we've got a poor peripheral blood flow, we do need to recognize that there is going to be underlying disease, whether that is something that's a PAD, but also they might have cardiovascular disease, risk of heart attack is increased, risks of angina are increased, and, well, everything that we worry about is increased along with their risks of strokes. So if we're able to identify that these monophasic pulses are present, then we can get the patient started on their pathway to possibly being healthier or just not dying, certainly not in the next few years. When we're assessing night pain and things that are going to be affecting patients' lives, when we're assessing whether or not they can walk with their kids to the park without getting their claudication or rest pains, these things are going to improve their quality of life immediately. And whilst certainly but in no way belittling the importance of identifying melanoma, the heart and associated conditions to the cardiovascular disease is going to kill patients a lot faster in all likelihood. And I've got the statistics to back that up actually as well. So you get a stage 1 melanoma and your chance of survival is pretty much 100% versus stage 2, 80, 70 and 30% for stages 2 to 4. Meanwhile, if you've had a significant amputation, you're probably looking at a 80%, well, anything between 50 and 80% chance of death in the next 5 to 10 years. Thank you for the warning, Osama, of the 30 seconds. So what we're able to do as podiatrists, and this is where we actually do get to save lives and limbs, is we're able to be that person that sees the patient on a regular basis, hear their story and hear them make that off-the-cuff comment that says, I'm getting a bit of an ache in my legs when I walk to the shops. And as a result, we're able to then refer on to the GP and get them on a path to exercise and getting the right medications to keep them alive for longer and keep their feet attached too.
I have to say, some fantastic stats there, equally convincing. So what we're going to do now is hand on to our experts. We'll start off with Dr. Ivan Bristow to try. We'll start off with Mr. Martin Fox to try and rebut the argument.
Thank you, Osama.
4 minutes.
Okay, so how do I rebut that argument? I mean, Zoe's made a very pertinent case there, but I think the key thing is the amount of arterial disease in our clinics compared to the amount of serious skin conditions. Although Zoe's come across with the big stats there on melanoma, at the end of the day, we're going to see far more people in the average week who've got arterial disease or likelihood of arterial disease in the lower limb presenting to us as general podiatrists or specialist podiatrists than we are necessarily going to pick up melanomas. In my practice, I would say that I tend to find a suspected melanoma perhaps once, twice, or 3 times a year. Now, I may be missing some, and I may need the Dermatoscope to help me find out more. But I'm picking up arterial disease in my general podiatry work at least 4 or 5 times a week. So the basics of whether we want to invest in one bit of kit or the other is really short-term thinking. But if you're going to buy one thing first to save more lives and more limbs, I would suggest it has to be the Doppler. It's a beautiful bit of kit. And if I've basically got myself a Doppler in my clinic versus a very posh magnifying glass, I'm going to use both of them maybe, but I can probably get away with looking at most of my skin lesions with this initially. And yet for the arteries, pulse palpation alone is not enough. We know that from the big studies now. So we have to have this little magical wand to help us hear that early disease before it gets to the stage of causing wounds or limb-threatening problems, and really tack it into the cardiovascular potential for living longer, healthier, less diseased lives by early diagnosis. So I make my case purely on the volume of arterial disease in the population and the average podiatry population than in the need for one or the other. And at that point, I think I'd like to hand over to Jeremy to come in and see if he's got any more points to refute Zoe's argument.
Well, I mean, I actually do have a fair few points on that. Well, not so much to refute it, just to kind of remind us of the importance of sticking in the 20th, 21st century. I mean, with the magnifying glass being basically developed around 1246 and Doppler ultrasound being something from 1942-ish, it is important to keep up with technology. And it's nice that you've got dermatoscopes. But when we're organizing a referral, being able to take a picture through a dermatoscope, speaking as someone who's tried, can be quite tricky unless you go the next level up for the ones that you can attach to your phone. So being able to boost your referral in that respect, it's going to be tricky. And likewise, the learning curve for using a dermatoscope is really quite brutal. As someone who is a really avid lifelong learner or just repeatedly single, I've ended up spending a lot of money on different skill sets, and certainly the dermatoscope has been the hardest to get ahead with. Whereas a few hours in a clinic listening to Dopplers on a regular basis, you'll be able to really get the hang of it. And whether you go for the top of the range Doppler where you can see the waveforms perfectly, or you go for a sort of much more entry level one, you're going to be able to pick up the big stuff like monophasic pulses, and then you can use other technology or other assessments to pick up the more sort of unique, discrete things. So you can use ABPI to identify the sort of peripheral vascular disease that we actually want to be catching. I think as well, when you look at the risk of death, it is actually much, much higher with malignancies as well. So, sorry, with amputations rather than malignancies. Sorry, Ivan, I know you thought you got me there. And then how much more time have I got? And then just to finish off, there is always the risk that you might look a bit like this.
You've got some great graphics there, Jeremy. Some interesting points there. Just quickly, viewers, if you've got any questions at all that you want to ask, do pop them in and we'll bring them up shortly. Finally, we pass on to Dr. Ivan Bristow for his 4 minutes of rebuttal against the arguments that Martin and Jez have made. Ivan, your 4 minutes start now.
Thank you very much. Well, just to say that I too have a fantastic vascular kit and I've been well trained. Thank you, Martin, for that. So I'm really just making the point that we should have both, but for the purpose of tonight, well, yeah, just to correct Jeremy there. If you're telling me it costs extra to have a camera attached on your dermatoscope and you can't afford £36.50, then you need to up your prices in clinic. But let's deal with the stats here. Now, in terms of dermatological conditions, they far outstrip any peripheral vascular disease, okay? But most dermatological conditions will not kill you, quite right. They don't shorten life. But if you look at the number of days which are lost through disability in dermatology, it is third in the world after back pain and depression, way above any vascular disease. So actually the disability and the long-term suffering for patients with undiagnosed dermatological conditions is incredibly high. Now, dermoscopy is something, just because it's difficult doesn't mean that you shouldn't do it. In fact, we need to take a handle on this. In my own routine clinic, in an average year, I will refer about 8 patients a year, and maybe half of them will have malignancy. Now, interesting, Martin gave the figures for peripheral arterial disease. Correct me if I'm wrong, Martin. Not all peripheral arterial disease ends up in serious amputation. There are numbers who will stay static. There are some that will slowly progress. Unfortunately, with malignancy, all malignancy eventually will shorten life. So in terms of the absolute figures, then I would say dermoscopy is going to give you a much more, a stronger ability to save lives, particularly as we as podiatrists, we don't have enough GPs trained in dermatology. As Zoe said, no GPs. You have zero need for training in dermatology to qualify as a GP in the UK. This is why we've got such a problem in secondary care. But Primary Care Dermatology Society is training every primary care clinician to pick up a dermatoscope and literally to go out and hunt the melanoma. But on top of that, for those in private practice and those in the NHS, it is a very good discriminator for benign lesions. Many things that end up in secondary care quite needlessly can be easily ruled out with a dermatoscope. And dermoscopy is great fun. But just to finally sort of put it all to rest to everybody here, one of the things that was not alluded to is how the dermatoscope is used to look at vascular disease like vasculitis, and by studying the capillaries in the nail fold, we can actually spot a lot of these vascular patients as well. So we have a dual use device here. So ultimately, yes, have a Doppler, have a dermatoscope, and I think the dermatoscope probably just pips it to the post here in terms of what you can do with it, and in terms of saving lives, and it's got a much bigger future. So I put it to all, I put it to the chair, that I think the dermatoscope will not only save lives, but improve the quality of lives of thousands of people, reducing waiting times and needless visits to dermatology. And this is all in our hands. We can do this and take it forward. I will leave it there, but I think that's a good way to finish.
No, I have to say, Ivan, I have to say some fantastic stats again, some great arguments that both sides are making here. It's really quite conflicting, isn't it? What we've had is one comment from Dr. Emma Cowley on Twitter, actually. She made quite a few, but I'll read one of them out. She said, neither instrument is any use in inadequately trained hands. So what are your thoughts? I mean, it's a very fair point, isn't it? I mean, if you've got a Doppler or you've got a dermatoscope, but you're not really too sure how to use them, or you can't interpret your findings adequately enough, well, it's not very useful. So, I mean, in terms of that argument there, I would say, Martin, what could somebody do if they've got a Doppler and they're not too sure how to use one correctly, or they're misinterpreting the results? What are the small little tips that you can offer that would make the most use out of that particular piece of kit in their clinic?
I think the main thing at the moment is to say, join the Royal College of Podiatry, because we're offering some really good quality CPD, including now what's been asked for many years by many of our members, which is a Doppler sound and visual database, which is going to be in the form of an MCQ online, available to members, where you can start to train yourself to hear the difference between the disease sounds, the monophasic sounds, and the irregular sounds, because we're thinking plumbing and electrics, versus the multiphasic and regular sounds. So I agree completely with Emma's point that in untrained hands, both bits of kit are useless. Podiatrists generally are probably more competent at the moment across the board with handling Doppler, just through as having had it in our clinics for the last 20, 30 years. So more of us are more competent, but we've got a lot to learn to maximize that competency and turn it into a life-saving and limb-saving clinical decision-making with our patients on a regular basis.
No, I have to say, absolutely brilliant. And in terms of yourself there, Ivan, so if someone's got a dermatoscope, because they've bought one, and you can easily buy multiple different types of dermatoscopes, often quite cheaply from various websites, how would somebody know that their dermatoscope is a good quality dermatoscope, and how would they be able to use that effectively?
Okay, I'll be pretty blunt. There are a lot of fakes and devices which are labeled dermatoscopes that are not. The average price of a professional dermatoscope that would be suitable would be for the full kit, including the camera attachment, Jeremy, would be about 800 to 1,000 or just over £1,000. But you only buy it once. The only thing you'd replace over the years would probably be a rechargeable battery, which would last 20 years. It probably lasts your career anyway. In terms of what you can do at the very basic level, you can measure, you can magnify, and you can take photographs. So even if you don't even know what you're looking at, you can certainly put it in a good referral letter to the GP, or if they have a direct access to dermatology, because as I say, a picture paints 1,000 words. The other thing to say about training is there are lots of places where you can train for dermoscopy. Now, all the details are on my website. Sorry, wrong way around. There we are, which is just there. But the Primary Care Dermatology Society, myself, and other groups run dermoscopy training days, a few hours, 3 to 4 hours. 4 hours will get you the basic introduction. If you really want to see how deep the rabbit hole goes, you can do a 2-day advanced course, which means that you're sort of pretty much able to spot melanoma at about a distance of 10 feet, but not quite literally. But ultimately, there is plenty of training available and information online on YouTube and so on, which gives some very good information. But there's a lot of information on my website, which is free to view.
That is absolutely brilliant. I mean, in terms of the Doppler, quick question there, Martin. So, of course, people have different types of Dopplers. Some are auditory only, and some show waveform. Just for the benefit of viewers, are you able to explain the sort of difference between the two, and how that can be used?
Yeah, I mean, the audio Doppler has been around for 20, 30 years, and is still extremely useful as a first-line diagnostic vascular tool. And as long as you can train your ears to pick out the monophasic versus the multiphasic sound, and irregular versus regular, and to be able to detect systolic pressures, you can use it in all areas of podiatry still to be excluding or confirming significant arterial disease. It's all the people that want to do nail surgery on, steroid injections, or deep wound debridement, to have gone in with Doppler first, even if it's only audio, would be, in most cases, enough. But we need to train our ears to recognize the monophasic. So if we're hearing the sort of wow, wow, wow sounds, we need to not see that as multiphasic and then think carefully before we treat. Whereas the dum 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 sounds, to keep it that simple, we know we're on pretty safe ground to do most podiatry treatments with that sort of sound coming out of both foot arteries. So audio or visual, it's like Ivan said earlier, you've got the choice of paying £150 or 800 for the kit, but equally you get what you pay for. And I'd say for the podiatrist buying now, the visual Doppler gives you more confidence in interpretation alongside the audio sounds that you're hearing. So that'd be my suggestion for people looking forward.
No, absolutely. That's completely brilliant. And we had a great comment from Jonathan Small here saying if you use headphones with a non-screen Doppler, that can work for differentiating mono from biphasic as the latter goes from ear to ear. That's a really interesting tip. Thanks for that, Jonathan. So We've also got another comment from Julia. However, even with the waveform display, if your angle is not right in the artery, you can get a false positive. So the best way to try is always try and find the best sound. Z shape, as Martin taught me. So we've obviously got somebody who's in camp vascular today, haven't we, in the comments? So absolutely brilliant. So in terms of the Doppler, just quickly again, Martin. So a lot of people are used to sort of palpating and Dopplering pedal pulses. Often popliteal can be a little bit tricky for some people. Have you got any sort of tips on how to go that bit more proximal if you're unsure about pedal pulses?
Well, Julia, who just came on, was one of our first Band 5 podiatrists in the NHS to be trained to go foot to femoral with Doppler in like, less than a minute. So per limb, you're listening at the usual 2 foot pulses. Then we listen on the outside of the leg above the lateral malleolus to perineal now, because it's an important little artery. And when you go to popliteal, the main principle is with an 8 megahertz probe, you have to press a little bit more into the back of a flex knee and slide across the popliteal fossa with the Doppler pointing still up towards the heart. And usually, if you're pressing in quite firmly there into a flex knee, you'll hear the pulse behind the knee, and you'll hear whether it's multiphasic or monophasic. If we consent patients reasonably to listen to the femoral pulse, which we should all be doing now without making a big song and dance about it, particularly when we're doing full limb assessment in our musculoskeletal clinics and we're assessing thigh pain or buttock pain that may be MSK related or vascular, we need to be palpating and listening to the femoral pulses. And it's really not a big deal once you've done your first 5 or 10.
Brilliant. That's great. I guess we've got one question for sort of the whole derm team here. So we're all familiar with things like skin cancers and melanomas. We can often be quite scary, and often when you're not too sure on a lesion, I think colleagues who are not trained in dermoscopy think, oh, I'm not too sure about that. But often what we do see quite commonly are the very common benign skin lesions we see, things like corns, VPs, for example. So how can a sort of dermoscope be useful in that setting there, Ivan?
Perfectly easily. I mean, in fact, it's a very good advertisement you just gave me there. My last month's blog was how to tell corns from warts using a dermatoscope. Very, very simple. Every skin lesion. The beauty of dermoscopy is it's like the auditory aspect is to Doppler. The beauty of dermoscopy is that every skin lesion has its own pattern. It has its own brushstrokes. It's like a lesion on a canvas, as it were. They have their own signatures. And certainly with, for example, you take a wart, a plantar wart, a verruca. If you debride that down, what you can see beautifully there, you see a picture like frog spawn. And in the middle of the frog spawn is a little red purple dot, which is the vessel which has come up, which is the ones that you cut through when you gently debride a wart, and it always ends up bleeding. But when you start to use a dermatoscope, you start to appreciate the histology. You can actually get that so much closer to the histology as you begin to understand the pathology more. And the same with nail fold capillaroscopy, where you use the dermatoscope to look at capillaries in the nail folds, because they come up very close to the surface. And this can be used to help in the diagnosis of vascular diseases, even connective tissue disorders like rheumatoid arthritis and so on. But saying that, there are so many common things and that are out there and have been reported. Over 7,000 papers have been published. The dermatoscope was invented in 1993. Since then, 7,700 papers up till end of last year, documenting and evidence its use. So it is growing at a much faster rate than anticipated.
No, that's absolutely fantastic. So the idea is that we cut to the summation aspect. So I want each team to be able to summarize their points as effectively as they can. And again, so you have to remember that the question that we're asking is, in a clinical setting, what is more useful? Is it a Doppler or a dermatoscope? We'll start with Team Derm. If you want to start your summation, you'll have 3 minutes. Zoe, you're up first.
Look, I mean, I think there's a place for both. Obviously, the whole point here is we're putting across information about both diagnostic tools, and I think they both carry their own level of importance at our first point of contact with patients. I think what I've learned through this sort of 2-3 week long journey working with alongside Ivan It's that we've got this clinical aid to our decision-making process, and that's also reducing the stress through the GP referral, through dermatology referrals, you know, and ultimately it's our stethoscope to the skin. And we have this amazing opportunity as a profession to be the first point of contact to identify those lesions in their early stages. And as we know from the literature, within 13 months, that lesion can turn into something completely different and threaten life significantly. And ultimately, when we're detecting these lesions earlier detection is going to save lives. And I too agree that, you know, Doppler is going to do exactly the same as that. What I will mention that there is a paper by Garcia et al. That looked at dermoscopy training in podiatrists, significantly increased their accuracy of diagnosing lesions, and particularly those suggestive of acral melanoma, which is present in 80% of cases, and that's within the foot. So I think it's important that we need to take into account, you know, our role as podiatrists as a first point of contact. Ivan, did you want to add anything to that?
Yeah, I would say, you know, Dopplers are going to be in a distinct advantage tonight because they've been around longer and we were all taught to use them at university through our training. And even I, as ancient as I am, we had a wind-up Doppler that you used to use and used to make funny noises and used to pick up radio too as well, but that's another story. But what I say to you is that pick up a dermatoscope, you can vastly improve your dermatology knowledge and keep it up to date, not just on malignancy. But what I say to you all tonight in trying to get you to support our case is dare to be different, you know, dare to be different podiatry. Dermatology needs you. The dermatoscope is the device that will help you to look after the majority of your patients. Remember, at any one time, up to a third of the population has skin disease, 59% of adults on their feet. It will help you. It will help your patients. It will help your practice, and it will help the professional profile.
Oh,
Have we still got 30 seconds?
We've got 30 seconds.
Get in there, Zoe.
No, I was just gonna kind of echo that and just basically say that throughout this journey, many of you know, 15 seconds. You know, I mean, I'm primarily MSK, but I've kind of learned the massive advantageous opportunity we have here as a profession, and I think dermoscopy has made me anyway.
Oh, it's time, Zoe. I'm so sorry. You're out of time, but yeah, very, very convincing arguments, isn't it? And it goes to show that it's sometimes a bit tricky. We're not too sure, but I'll pass on to Martin and Jazz for their 3-minute summation.
Jazz, do you want to start?
Yeah, thank you very much. So
3 minutes begin now.
Thank you very much, Osama. I think I echo the thoughts of both Ivan, Martin, well, everyone here. No one's going to say that either tool is more important because you need the tool that you need the tool for the thing that you need the tool for. It's really important to make sure that we're using the right things for the right patients, good governance and all that. So we can do a 1-minute foot to femoral check and a 2-minute toe pressure check. We can do a 3-pulse check as well. And in that time, that takes less than 10 minutes. And then patients live for longer. Pretty good. Whatever we do need to have blood flow there. And ultimately, if we were to do what Public Health England wants us to be doing by, I think it was 2029, 85% of AF cases would be identified, 80% of hypertension, 75% of 40 to 74-year-olds would be identified as having cardiovascular, or if they have cardiovascular disease, by 2029. And with that, we'll save 68 billion, or 4.9 million quality assessed life years. And then there's possibly 3.4 million cases of cardiovascular disease prevented over 25 years. So actually, we've got some pretty good statistics there. And, you know, looking at some of the old amounts that have been saved for cardiovascular disease screening versus skin cancer screening, there is a huge difference. But that's not to say that skin cancer assessment isn't important. And actually, if you're doing a vascular assessment, you should be assessing the skin too. So you're not going to find me arguing that dermatoscopes are rubbish, just that Doppler might be more useful for a wider portion of our population to start with. But since I've had a dermatoscope, I have learned so much. I'm going to hand over to Martin as well.
Thanks, Jeremy. I mean, basically, we've got 10,000 of you out there or more. It's 10,000 podiatrists. That's 500,000 contacts with people per week on average around the UK. We've got 1 in 4 people in the UK die of cardiovascular disease. PAD is a cardiovascular disease, and 1 in 5 of our over 60s. So the value of one bit of kit against another, the numbers are just huge for cardiovascular disease and vascular disease. We're saving lives, we're saving limbs with early diagnosis, picked up by the Doppler, the first port of call. And last of all, to keep us safe in podiatry, in whether we do elderly nail care, nail surgery, connective tissue disorder management, diabetes, wound care, all of these things, MSK practice, we need to be safe. And particularly if we're injecting or debriding, we need to be safe. And the Doppler helps to make us pause and think before we dig any sharp instruments or needles or blades into the soft tissue of the foot, which Ivan and Zoe are also trying to protect in some ways. So we need Doppler.
That's absolutely brilliant. I'm sure you'll all agree, some fantastic arguments made on both sides. So it's down to you all, viewers, to vote. The voting poll should be opening up soon. And well, it's a very tricky one, isn't it? I mean, as people have said, and as both camps have said, both are very, very useful in clinic. But I guess the question we're asking tonight is which is more useful? And as I was saying, some excellent arguments made. What we are going to do is cut in true TV fashion to an ad break, advertising tomorrow's Podiatry's Awards. Brilliant. So make sure you get your nominations in by the date at tomorrowspods.com/awards. I think just in the comments, we've got a comment from Sarah and Jane Walls. Great to see you, Sarah. I think we've got a convert here. So Sarah says, same as Zoe Wilson, I'm an MSK pod mainly, so haven't really considered the extent of dermatology, but like you discussed, I'll happily use Doppler, no problem. I haven't considered dermatology. Thanks to all. This has made me consider I need to invest in the dermatoscope and training. Absolutely brilliant there. We had an interesting comment from Lauren earlier as well, just saying, well, looking at misinterpretation, what's the likelihood of missing something significant due to misinterpretation or poor technique on both sides of the argument? So some great thinking there, some great thoughts there, and it's all very, very useful. Now, I had a quick question for both Ivan and Martin here. So for those who are listening and watching and thinking, well, actually, I've been really convinced here. I'm MSK or I'm vascular or I'm dermatology. I haven't really thought about the other side of the coin. And actually, I'd like to do some bit more training, for example. What sort of signposting can we advise our viewers on what to do next and what steps they should be taking to train either in vascular podiatry or dermatology? Over to you, Ivan, first.
Okay, well, first up, just a quick plug, foot.expert. There are a range of places that will do dermatology training, but also dermoscopy training. It's not all just down to me. There are lots of good people. The Primary Care Dermatology Society probably they train the most in primary care, but obviously we're more focused on feet. So some people come to me. There are other organisations who offer it, but between them, they're offering courses 4 or 5 times a year all around the country. So geographically, you shouldn't be disadvantaged because both groups offer training also online, out of work hours on the evenings on Zoom. But full details are on foot.expert or the PCDS website, which is pcds.org.uk. And there's lots of information on YouTube.
Absolutely brilliant. Thank you, Ivan. And so in terms of viewers are thinking, well, actually, I've got a Doppler. It's somewhat useful. I'm checking it here and there, but I'm not too sure I'm making the full use out of it. what are the next steps they can take, Martin?
I think I mentioned earlier that the Royal College of Podiatry is updating its CPD, and we're going to have a very Doppler-focused resource on there, which I think will be most useful for that layer of confidence and capability development with many podiatrists. And then on top of that, we've got the 1 or 2 day vascular modules that are offered. That we're touring around the UK this year with them. So Northern Ireland, Scotland, and Wales are all getting the options for a vascular podiatry 1 day, 2 day course with blended online and face-to-face content. Then if you're really serious about developing a career in vascular podiatry in your sort of area of practice, then the level 7 modules around the UK in various higher education institutes will be the best next step. Either a cardiovascular focus module, or there's a vascular module down in London, which was primarily driven by the vascular nurses, our colleagues there. Many of us in the Northwest did a course a few years ago, Edge Hill University in vascular skills, but the London course is the only one that's very vascular focused right now. So I'll be starting to think about that as a career move. And there's nothing better than getting onto clinic alongside a competent other and getting them to really help you with the basics of handling the Doppler and using it in combination with ankle or toe pressures.
Those are some excellent tips. So if any of you are thinking of exploring the world of vascular podiatry or dermatology, we've got some great links there to upskill ourselves really and offer our patients the very best to improve patient outcomes all round. So I think the results are in. Well, the question we asked was what is more useful in clinic, a Doppler or a dermatoscope? Today, Team Doppler has won the vast majority of the vote with 79% of the vote, and Team Dermatoscope have got 21% of the vote. So we've got a huge push for Team Doppler. But I got to say, it's excellent arguments all the same, valiantly fought, and it appears that through the whole debate and the discussions, people have changed tack and they will actually, hang on a minute, I'm thinking of doing some more dermatology training, or hang on, I think I'm doing some more Doppler training. So, but I guess the basis of everything is we are all looking to improve our skill sets here, again, to improve patient outcomes. And that's the ultimate goal here, isn't it? To improve what we can offer to our patients. Absolutely brilliant. Well, thank you to everybody for taking part in this absolutely brilliant debate. I've certainly learnt loads just during the past 2 weeks getting involved, speaking to various people and speaking to our experts here. Thank you to our team captains, Zoe and Jez, who have done some brilliant work on this. Thank you to our experts in the field, to Dr. Ivan Bristow, Mr. Martin Fox. Well, I think Martin wants to come in just with a quick question.
Osama, it's a question for you. I'm dying to ask you, what would you rather have in your clinic as the first purchase?
That's absolutely brilliant. Well, I have to say that I've actually got both. Got a Doppler and a dermatoscope, and I'm always looking to increase my skill set to use both. If I'm honest, I'm a person. Well, I do love a Doppler. My undergraduate thesis or dissertation was on ABPIs. I have to say. So yeah, I mean, it's all about improving as much as you possibly can. I've joined the PCDS, Ivan, and I'm joining their annual conference in 2 weeks' time. So it's a case of, well, I've got 1 foot in each camp, haven't
I? Very, very diplomatic answer and well chaired.
Thank you, Martin. That's very kind. Thank you. So yeah, just finally say thank you very much indeed to everybody who got involved. But I guess the question we've got is, this was a pilot episode for our brand new show, and we are looking to do more of these as time goes on. So if you could just pop into the sort of comments, what debate you'd want to see next, that would really help us out. Thank you to everybody for joining, and thank you to you for watching at home and joining in. We'll see you next time. Good night.